Hello, everyone. Welcome to our Timely Topics webinar exploring effective global health communication during chaotic times. I'm Michelle Berry, Director of the Stanford Center for Innovation in Global Health and Senior Associate Dean of Global Health at Stanford. During my decades-long career in global health, I've repeatedly witnessed that bad messaging of health informations actually costs lives, worsens outbreaks, and creates unnecessary stigma. We've seen this play out tragically time and time again, from Ebola outbreaks in the 2010 era to COVID-19 and the rise of vaccine hesitancy, and to the more recent Ebola and hantavirus outbreaks. I believe doctors have an important role to play in making science more understandable and accessible in order to influence health behaviors. They need to overcome the lack of trust that has emerged in the US. For this reason, 15 years ago, I established the Global Health Media Fellowship in collaboration with the chief medical correspondent at NBC News, Nancy Snyderman, to train a generation of physicians who could provide a trustworthy, factual information to the public in times of medical crisis. Now, in partnership with CNN, Sanjay Gupta, and Stanford Journalism, we've trained 15 outstanding fellows who've gone on to develop their own communication training programs for medical students at their institutions. They've launched new fellowships and work as producers at national news outlets. One recent fellow, Neha Mukherjee, who you will hear from, teamed up with a mentor and collaborator from the fellowship and recent WHO communications director, Gabrielle Stern, to develop a Nature Health publication highlighting recommendations and best practices to help anyone who cares about communicating good medical information, from doctors to science communicators to public officials, and do it so effectively. We hope today's event will highlight best practices for doing so during this time of great disruption in health and media, and with AI in the background. We're lucky to have Dr. Eli Cahan moderating our excellent panel. Eli is an award-winning investigative health journalist whose work has been published in ProPublica, The Washington Post, LA Times, Rolling Stone, The Guardian, and Vice, to name a few. He directs the Stanford Health Media Fellowship, which runs in parallel with our Global Health Media Fellowship, and offers a paid graduate-level training opportunity for doctors and journalists to help fill the gaps in a solutions-driven reporting on health equity across the U.S. He's also a Stanford neonatal intensive care fellow and a postdoctoral affiliate at our center, the Center for Innovation in Global Health. Eli, over to you.
Thanks so much, Michelle, and thanks for setting this up. Obviously, thanks for the work you've done, paving the path, really, for those of us who have tried to come after you and thinking about this sort of under-discussed intersection of communication and public health. And I think, Michelle, as you said, you don't have to read too many articles in the news to understand I think, first of all, fundamental fracture between public trust and public institutions, government institutions, as well as civic institutions. If you look at public perceptions of institutions across sectors, whether they are healthcare institutions, criminal justice institutions, social welfare institutions, economic institutions, you will see a secular trend in recent years that demonstrate that all of these institutions are seeing a fundamental and unprecedented fracture in the level of public trust. And often, if you look at the surveys, the most recent year on record is the lowest year on record in terms of the level of trust that the public has in these governmental or civic society institutions. We know that trust in healthcare is particularly important. That is especially the case in several settings. For example, when you think about populations that are vulnerable or require long-term care, whether these are the kids that I think about, right, vulnerable infants, or older people with chronic disease, they are trust is important in healthcare if you think about rapid response, whether it's to pandemic pathogens or natural disasters. And trust is important in public health when you think about all the things that we as scientists, as researchers, as clinicians tell people. Believe us if you do this today, if you stop eating, red meat or stop smoking, or, we're not so sure about peptides, that these things will promote wellness, health, and quality of life later on. And without public trust, the ability of healthcare institutions to serve the public is really impacted. I think we've seen some of these in really vivid render recently. Whether you think about the Ebola outbreak, the ongoing Ebola outbreak, the hantavirus outbreak, the ongoing cyclosporiasis outbreak, to say nothing of things like vitamin K, vaccines, extreme heat, which I'm calling in from Europe, and it has been less hot than it has been the last couple of weeks, but it is extremely severe. The ability for people to stay healthy and survive these circumstances is really dependent on public trust. Likewise, if you look at the data on the trends in uptake of interventions that depend on trust, amid rhetoric that has either been equivocal or has gone counter to traditional advice related to health, you will see already changes in behavior. So, for example, in the US, those are things like hepatitis B screening, things like vitamin K shots right after birth. And we are already seeing the impact of mixed messaging and either failure to debunk misinformation or perpetuation of misinformation from health institutions, as well as prominent voices. And the inability for doctors and public health practitioners to effectively combat that rhetoric is already showing demonstrable impact. So to combat misinformation, we need all hands on deck. And to that end, we think that everybody's a potential communicator. That's why, Michelle, I know you've been training med students for 15 years. That's why we run the fellowship we do. And that's why a lot of us here at Stanford are thinking really hard about how can we better train public health experts, scientists, researchers, doctors, and many others to communicate at the bedside and at the systems level to keep people healthy. To that end, I feel really lucky that we have such an amazing panel here with us today who have a wealth of wisdom to that end. And so I'll just go through and I will introduce them, with the caveat being there is no way that I can do justice to any one of these people, because we could spend the next 52 minutes going through the bio of any single one of them, but we won't do that because that would be boring. So we're just gonna run through it. So I want to introduce our panelists. The first one is Neha Mukherjee, who Michelle spoke to. Neha was the 2024 to 2025 Stanford Global Health Media Fellow and is now a fourth-year medical student at the Icahn School of Medicine at Mount Sinai. She graduated from Brown University with degrees in public health and journalism, and her work has been featured in lots of places, including CNN, NBC, Wired, San Francisco Chronicle, Nature Health. Next, we have Gabriella Stern. Gabby is a research fellow at the Harvard Center for International Development at the Harvard Kennedy School and a senior communications advisor at the Harvard T.H. Chan School of Public Health, where she's also journalist in residence for the Center of Health Communication, which I have very fond memories of during my time there. Before that, she was the director of communications at the WHO, which she managed for 6.5 years, including during this little thing called the COVID pandemic. Before that, she was director of media external relations at the Bill and Melinda Gates Foundation. And before that, she was an exceptionally accomplished journalist in her own right, reporting and editing at places including the Wall Street Journal. Third up, we have Ben Johnson. Ben is the chief editor of Nature Health, which is one of the leading academic journals shaping the conversation in the Nature portfolio. Ben, for his sake, has a PhD in infectious diseases and has been a prolific researcher in particular in the fields of virology and vaccine research at Public Health England and Imperial College of London before he moved into academic publishing. He's previously served in publishing and editorial roles at BMC, Springer Nature, and Nature Medicine, and has a strong vested interest in all things communication and public health. Last is Omar Sise. Omar is a medical student, aspiring neurosurgeon at the University of Nebraska Medical College, and he's the incoming 2026 to 2027 Global Health Media Fellow. So we feel extremely lucky that we stole him away for a year in his journey. He has long been doing work aimed at reaching underserved populations through quality healthcare and communication, including derived from his own personal experiences growing up in the Gambia, surviving a malaria infection and witnessing his father's preventable death due to a lack of available neurosurgical capacity in his own country, as well as an absence of preventive health measures. So, thanks everybody for joining. We have got a lot to run through. We're going to do some curated conversation, and then we're going to aim to take Q&A. So start thinking about any questions that you have now, and you can start typing them into the chat whenever, though we will take questions at the end. I think we should start by just everybody sharing some of the experiences they've had firsthand, what you've seen firsthand in terms of when communication goes terribly right and helps people, and when it goes horribly wrong and with potential health consequences. What does that look like in real life? Why don't we start with Gabby on this one?
Hi, Eli, and thanks, Michelle and Jamie and Ola and everybody. Hi, everybody listening. I bring to the table many unanswered questions. Okay. A lot of experience, a lot of lessons learned. And I'm a voracious reader of the literature and the research on communications generally and health and science communications specifically. Yeah, when I was running communications during COVID at the World Health Organization, I would say that was, I'll speak about that because that was both the most, it was an incredibly difficult period for the world. It was difficult for WHO, and my team and I at WHO had this incredible job of trying to tell the world, and the world's a very big place, what was happening with COVID. And to me, the biggest, well, there were many lessons learned. And it is through that experience plus the research that I'm, 100 million% convinced of a few things. First of all, the tendency of institutions and experts in the face of a health crisis is to preach, to be the sage on the stage, to get out there and tell people, this is what's happening, this is what you need to do. And that's a very natural human behavior, especially for doctors and PhDs and researchers and nurses and all of us who go into this field because we want to help people. So we think, let's tell people what to do. And when you do that, you're automatically putting people off because you're subordinating them to you. You're the sage on the stage. And so I think the biggest takeaway from my experience at WHO, but also I think the literature increasingly tells us that communicating health and science must be a shared journey between experts and lay people. And in fact, that lay people can tell experts and teach experts about as much as an expert can teach a lay person. And that experts can, by really listening to, conversing with, observing normal people, will actually benefit by taking cues from lay people. And one example is early in COVID, people around the world as the scientists were trying to figure out what this new virus was, how did it behave, how did it transmit, as that work was ongoing, normal people were doing very sensible things to protect themselves. They were making homemade masks or putting scarves on. They were starting to take very sensible measures to protect themselves. And in many ways, they were ahead of guidance from countries and from global authorities on community masking. The advice right from the start, of course, health workers needed to mask up and use the best masks because they are most exposed, right? And care workers and people who are really on the front lines. But community masking was not in the guidance for a number of months, but people were masking up in communities. And that's a beautiful example of how experts can open their eyes, open their ears, open their minds, and really learn from the people that they are trying to impart their expertise to. So I have a lot of other lessons learned and important tidbits from the literature, but I think I'll leave with that so you can go on to the next speaker.
Yeah, thanks for that, Gabby. And we will certainly work on unpacking all the lessons learned that you experienced. I want to move next to Omar. Omar, in your experience, when Gabby says, refers to this sage on the stage dynamic, when do you see that being useful? When is expertise a useful thing coming from institutions? And when is it harmful in terms of empowering people to respond quickly to evolving health threats or respond over time to things that they have to deal with over the long run?
That's a wonderful question. From my experience as both a medical student, social media creator, and previously an ER nurse, I think the knee-jerk reaction whenever we encounter a patient is to assume that they are misinformed and needed more information. And misinformation's antidote is not more information. It's sometimes to find out what is the basis for that misinformation. And it's usually um, used to cure some sort of fear or trauma that the patient has received in the past. Once you diagnose what the basis for the misinformation is, then it is easier to give responsible sets of guidelines or information that will be helped to care for this patient. So without identifying that core basis for the misinformation. What patients usually see attendants or medical students do is act as if they're dismissing what they are saying, as opposed to saying, I can agree with your emotions without agreeing with the myth behind the emotions. So a typical example that I have for this was a patient that we were taking care of in the ICU. The patient was put on antibiotics and then developed C. diff, which was caused by the antibiotic that they were on. Our team came in and wanted to put the patient on a second set of antibiotic, vancomycin, and her daughter was furious because you had given my mom an antibiotic that caused this diarrhea, and now you want to give her more antibiotic. So in that case, the daughter wasn't opposed to curing the parent. They are opposed to the idea of giving more medication that had, in the first place, caused the problem. And so we would have been triggered to say, well, the antibiotic is going to fix the C. diff, but they didn't need more information as to what the antibiotic was supposed to do. They needed their fears like addressed first. Why do I need more antibiotic when antibiotic is the thing that led to the problem? And our attendant was able to successfully explain why the secondary antibiotic was needed. Now, um, an alternative example to that was witnessing an attending talk to a parent who was refusing to take a vaccine for their second child. And the attending was quick to say that this vaccine was this percentage effective. Uh, that parent did not or wasn't requiring to know how effective the particular vaccine was. As far as they were concerned, their only child, prior to this second one, took the vaccine and had an adverse response. So to them, it was 100% not safe and 100% not effective. And so quickly telling them how effective or safe it is was not the right thing to do in that regard. And we totally missed the opportunity to address that. And so that's potentially one patient parent whose mind could have been changed by about vaccines that we failed to be able to change their minds. So those will be the two key examples that come to mind.
Thanks, Omar, for sharing that. Those are great examples, and I think it's a natural handoff to Ben because we're talking about statistics. Obviously, so much of scientific research is premised on statistics, population averages, normal distributions, these sorts of things. I guess I'm curious, as you think about the work that you work with your authors to do every day, and the literature that you are disseminating that forms the basis for healthcare information and decision making. How do you think about communicating statistics in the setting where to individual patients it's 0% or 100%, or to individual patients when it comes to their parents, whether they got C. diff was 0% or 100%? And it was, correlation is not causation, but they took a medication that they hadn't taken before and then they 100% got C. diff. So what happens next?
Thank you, and thanks for the question, and thanks for inviting me to join this very interesting panel. It's a real challenge, and I think if you look at again some of the survey data, there's a huge decrease in people's confidence to make health decisions. So there's a survey by Edelman, and they show a 10-point decrease from last year to this year. I mean that is a crazy, massive decrease for a global survey. And I think part of that is the increase of information. So slightly paradoxically, the more information you have available to you, the less confident you are to make decisions, combined with the decrease in trust that you've seen, trust for institutions, trust for experts. I do think I totally agree with what Gabby and Omar have said, that trust and listening are really key. But I think there is another issue that you've mentioned, which is around, I suppose, health literacy or scientific literacy. And some of these numbers and stats are hard to understand, and they're hard for other researchers sometimes to understand. And things that you learn if you're doing a science degree or you're studying medicine, you learn about the difference between correlation and causation. And you might learn about what's sometimes called the hierarchy of evidence, where if you want to show this exposure causes this disease, ideally you do a randomized control clinical trial, because that gets rid of all these other kind of artifacts and confounders and issues. And then you have observational research, and you have kind of cell culture, preclinical research with the lowest evidence. This is complicated, right? I don't think we should pretend that it isn't, but it is also possible to understand this. And I think that's one of the things we saw during COVID, was that actually everybody has evidence. It's not that the kind of false health claims don't have evidence. There is evidence. I mean, to use a famous example around the link between Tylenol and autism, there is evidence of an association for mothers who take Tylenol. There is a higher incidence of autism. Whether that is causing it or not is the question. And there's very good evidence that there is no causal link. You're more likely to take Tylenol during pregnancy if you have a fever. Fevers can be associated. There's a whole bunch of other associations there. And I think one of the challenges is, as I say, everybody has evidence, and there's a huge amount of scientific evidence published every day, part of which I'm responsible for. And it's not necessarily I think we've not done we kind of need to do a better job to, I think, educate the public and educate patients around I guess, how to make use of that evidence, and find ways of communicating it that are engaging and that are easy for people to understand. Because as I say, I know that also there's a lot of people with PhDs who also sometimes send us papers saying this causes this, and we look and say, no, this is an association, it's a correlation. So that's a challenge. That's more of a challenge than a solution, I think.
Well, let me ask a follow up on that, Ben, because I think this language around health literacy has been around as long as I've been in training, and I think as you suggest, some of the most deeply educated, perhaps deeply overeducated human beings on Earth may struggle to understand health information that's not communicated well. And I know this because I think anyone who's been through med school knows the story as old as time of the brilliant scientist who, discovered a protein and gave the worst lecture of the year because they just don't know how to communicate this thing. And so I wonder, as you think about your role in disseminating information and in curating the conversation around what information's out there, what is the balance between, trying to work with, meet people where they're at on the basis of the health literacy that they have at baseline, versus trying to do your darndest to communicate in a way that makes health information accessible regardless of someone's background knowledge.
So I think to kind of steal an idea from the article that Gabby and Neha wrote for Nature Health that I had the pleasure of editing, I think there is a question around who is a health communicator. And actually, I think everybody, it should be as many people as possible. I think everybody needs to be trained in health communication. But I do think then there is a role for the specialists as well. Actually, not everybody anyone can learn to be a communicator, but I think there are some people who are very gifted at communicating, and I do think they also need to be utilized. I also think it's something we need to do more of as a publisher. I mean, Nature has just joined TikTok this year, I think, or last year. I launched Nature's Instagram account about 7 or 8 years ago, which was thought to be a really like strange thing to do. Like everyone kind of said, why do you want to do this? But we'll let you do this, but we're not quite sure why. We, as a publisher, we need an Instagram account, but you need to be where people are, and that's social media. I also think one of the topics we'll probably come on to is around AI. Almost everybody is using AI to ask health questions, and we need to make sure we, the kind of scientific community, and I think we have a role as journals in trying to make sure these tools are safe and effective, because that's also a potential solution as well. You need to be on the platforms where people are asking health questions, and a kind of a word of reassurance as well. Like people do trust their physician in general, like super high levels of trust for their nurse, their physician, their community health worker. So particularly if you are in ill health, that is somebody you will go to, most people will go to and will have a really high level of trust for. So everyone does need to be able to, everyone in that role does need to be able to communicate well.
Great. Thanks, Ben. Neha, you're now at the tail end of your med school journey. What have you seen firsthand in terms of how doctors communicate at the bedside? And do you think that's working? Do you think that's not working, and why?
Yeah, hi Eli. Hi everyone. Thank you for having me. I think, and this has been touched on a bit, there's a lot of medical jargon thrown around, and I think often we forget that we've spent like years and years like poring over books and training to understand these words that we just expect our patients to know somehow. And examples that come to mind are like when I did a pediatrics clinic and a doctor asked a 6-year-old, do your toes feel numb? And the 6-year-old looks at him like, I don't know what numb means, and it's like little examples like that where you could say instead, like, oh, do you think you can feel your toes? Like, if I touch this, like, does it feel the same on both sides? Similarly, in the emergency department, I've overheard physicians ask patients, do you have hypertension? And they say no, but then you ask them, do you have high blood pressure? And they say yes. So I think part of it is trying to understand where our patients are coming from in terms of their understanding level, and what can we do to kind of bridge that gap, because our end goal is the same, to get patients the best possible care. But I think observed over and over again little missteps, and not on purpose. I think we all get immersed in this common language that we speak, but I think it's important to try to bring it back to how we were before we started medical training, and the words that we use with our loved ones and the words that we use outside of clinic settings as well. So small change that can be made, but that's something I've observed here and there.
Great. Thanks, Neha. I want to move into the conversation about, where are people getting their health information? And it's interesting because, on the one hand, misinformation became sort of a term of art during the pandemic, with a sort of shared understanding, I think, in the medical field of what misinformation means. I think also, the way in which misinformation is dismissed as invalid by traditional health institutions threatens potentially the opportunity to understand how people encounter health information and what health information or advice actually resonates with people, because I think it potentially implies that someone doesn't believe something only because it's wrong, which I think we know across all sectors that people will believe lots of things agnostic to the truth value of them if those things are described in a way that's compelling, accessible, and meets them where they are. Enter that dynamic, the era of AI, right? And so I suppose I'm curious to hear from the panel where they see whether they're patients coming into hospitals or engaged citizens with matters of health that are important to them, where folks on the panel see this information coming from, how they see the evolving landscape around AI and social media influencing the way in which people receive and interpret health advice. And I think for this section, maybe Omar, we can start with you. I'm curious, what have you seen in terms of the way in which communities are encountering health information? Where are they getting health information? What does it look like? And what are the ways in which that is compelling compared to the way in which institutions traditionally have communicated?
Yeah, no, that's a really wonderful question. I think given the current era of AI and social media use, we tend to overestimate what percentage of the public actually gets their information from online sources. Of the seven major places that patients get information from, still 85% of people get information from doctors. Now, that information, when dissected, based on like race and gender and income status, changes quite drastically. So people that earn less than $100,000 are more likely to get information from online sources. People that are underinsured, 50% versus those that are insured, 34% get information from online. And so when you look at like the different social media platforms like Instagram, YouTube, and Facebook, for people that are 65 and above, 60 to 58% to 60% of people that are 65 and above tend to use some sort of YouTube or Facebook. If you look at people, my generation, which is like 18 to about 29, that generation for Instagram use is about 78%, right? And so, depending on what the topic is that this person is interested in, healthcare providers might be able to target a certain group with exposing them to a certain information. Depending on what this person's need is for the information that they are looking for, is what tends to guide where they go seeking that information and what they actually have access to. So people that are not able to go see their primary care provider would turn to the internet more frequently. But even for those that have access to primary care, in between the two primary care visits, when they needed an immediate answer, then they're more likely to turn into online sources that will just give them information readily. And so I think while we're trying to address like these information gaps and understand more so where people get their information, it's not just enough to understand the broader terms, but to be able to break those down so that we could be more effective in disseminating information.
Great. Thanks, Omar. Gabby, I know you've been thinking a lot about social media, about AI, where people are getting information, misinformation. I also know in your capacity when you are at the WHO, obviously this was sort of a marketplace of ideas, quite literally, that you guys were wading into and rolling up your sleeves in. What have you seen in terms of the evolution in the ways that health information is communicated on social media, including by AI? And how do you think health institutions can and should respond?
Um, we're living in a golden age of digital and multimedia communication. I'm 65 and a half, and when I was coming up in journalism, you had paper and you had landlines. So today, our ability to reach either large numbers of people or, to Omar's point, to precisely meet people where they are with the kind of, on the platforms where they are and the kind of formats that they appreciate consuming, whether it's video or audio. It's incredible, the tools we have, and it's all in our devices, in our hands. On the other hand, and so at WHO, we were on so many social media and search platforms and WhatsApp channels and so on. AI is changing everything. And this is why I really think we need a lot of research right now into how to help people with their discernment. The empowered patient needs to be a patient who can discern between experts. Experts don't agree with each other. So if we try to go back to some kind of golden age where people trusted experts, that's not going to work, because experts are feuding behind the scenes and very publicly. Oh, and these are experts with maybe the same degrees from the same institutions. So people need to be able to navigate information ecosystems, make do critical analysis, and make sound judgments for themselves and their communities, because of course health is interlinked, and my health and your health is our health. With AI, and I'm quite an avid user of AI, AIs hallucinate. And so we have to help people push back against the AIs and ask questions and make the AIs recheck and recheck and recheck. I'll give you a little example. I am an aficionado of Victorian English literature. And lately, during my drives around Boston, I've been asking the AI about plot points. And the AI, despite a very simple task, you'd think, which is to analyze text, gets plot points wrong, not only wrong, but invents plot points. Abandoned babies who don't exist in a novel, characters who don't exist. I say this because the advent of AI and the people's use of AI, which is exploding, the AI can be incredibly useful, but the patients will have to exercise their discernment and know that they have to push back, push back, push back, verify. And this is a real conundrum and a huge challenge for us. I really believe it's changing things, which is why what we're doing, all of us who are in health and science, as clinicians, as editors, as researchers, and so on, it's an amazing time to be doing this, because the ground is changing. It's moving under our feet now. I mean, as we speak. I don't know if that answers your question, but that's on my mind.
Yeah. Ben, obviously, AI is not just limited to interpreting health information that's out there. There's a very lively conversation within the academic literature about the place for AI in performing analyses, in drafting and editing manuscripts. And so I wonder, what are you seeing in terms of the use of AI when it comes to the actual production of the literature? And then what are you seeing in terms of the ways in which research is being communicated on social media and other platforms by humans as well as by AI?
Yeah, so AI is kind of everybody's obsession at the moment, and it's changing everything. I mean, it's changing how we work as a publisher. We publish articles using AI. We publish research highlights partly written with AI. We have a tool called Nature Research Assistant, which will analyze your paper and will help you write a paper like a Nature paper. Um, so it's changing everything. I think I think there is a real opportunity there, but there's a huge challenge because they are not. There's no current legal requirement for them to be safe and effective. There is an argument that they're a software as medical device, which is a legal framework, a regulatory framework, but actually, for a general chatbot that they're not pursuing that. So there's you ask a health question, there's a disclaimer at the bottom saying this is not intended to give health advice. And we don't know. We really have absolutely no idea if they're safe and effective, unlike other kind of diagnostic tools that people may use. So I think there's a couple of things. I think one is trying to show whether or not they're safe and effective. And actually, the tech companies are mostly interested in this. I mean, if you look at what people at like people at Google, Microsoft, OpenAI, they will openly say that health is one they see as one of the key uses for their AI models, consumer health. So there's a couple of projects we're working on at Nature Health. One is trying to benchmark these general health AI tools. So how is it at the moment we don't even know how to assess if they're safe and effective. So it's trying to find a way of doing that, whether it's getting a load of humans to ask a load of questions and then recording the answers and comparing them with the answer an expert would give, or whether it's going deeper into the algorithms, whether you can have a way of flagging a website which has quality health information that then feeds the AI. There's a bunch of ways researchers are looking to do that. The other, which has been mentioned already, is we all need to know how to use AI tools. And this is called prompt engineering. It's a new job you could go into. It's like how to write the prompt to get the answer that you want, to get an accurate answer. And this is a kind of evolving science of its own. We're working on something called the Health Chatbot Users Guide, which is with patient advocates, some journalists, researchers, trying to kind of develop a user-friendly toolkit for people to that people can use. But this is a yeah, this is a definitely we're really at the infancy if you think how recently ChatGPT was released. So this is a very I'd say we're in the very early stages of this field, which is a challenge because millions of people are already clearly using these tools.
Yeah. So I think, in this kind of tsunami of information, I want to sort of move to maybe the last sort of portion of the curated conversation, which is talking about solutions or opportunities or skills that listeners on this call, can use in their conversations with individual patients, in their conversations over social media, and in their conversations through institutional lenses to try to combat misinformation as well as communicate more effectively. Neha, I know this is something that you've been thinking about a lot. Can you share some of your thinking around frameworks and strategies that clinicians and health communicators can use to more effectively engage their constituents?
Yes. I guess when we think about, trust in the medical community at large, I think very much about that like provider-patient relationship. While I was at CNN reporting through the Global Health Media Fellowship, I focused most of my time on reporting on the measles outbreak in early 2025. And when we talk to public health workers on the ground and we ask them, what actually helped to resolve this outbreak in the end, they really talked about individual conversations that providers had with their patients, encouraging them to get vaccinated. And this was in a highly under-vaccinated Mennonite community, and it's a challenge to encourage people to change their public health behavior, but they really attribute their success to that individual relationship. And I think that that tells us that if we want to change public health behavior, maybe we need to invest a little bit more into what the research tells us can help patients really trust their provider. And there's this book I really like called Compassionomics, and it talks about the fact that compassion can really make a difference in healthcare outcomes. They cite a study in the book of medical students who were being observed by attending physicians, and how the medical students that showed more compassion to their patients, both in the forms of listening before speaking and even in like nonverbal forms of compassion, like, good eye contact, those medical students were actually perceived to be more competent. And the study actually showed that they were rated 15% more competent than their peers who were not showing as much compassion, both in verbal and nonverbal ways. And both their attending physicians observing and the patients perceive them as more competent. So I think, while it might be simple, maybe part of what's missing in this whole realm of trust in the healthcare institutions is that like basic compassion in clinic rooms. So I think, when I'm thinking about trust at large, I think revamping and paying, really specific attention to that relationship can be extremely helpful.
Awesome. Thanks, Neha. Omar, how are you thinking about the ways in which health communicators can do this better?
Yeah, I think this is probably one of the biggest, topics regarding what we're doing today. And I would say that healthcare officials and doctors are not unique in this regard. I think the data has been showing that trust in the average citizen for like the federal government, like currently it's about 20%. That same number, like in the 1965, that used to be about 73%. And so with regards to like trust in banks, public schools, those are all around 30%. So doctors for the level of public trust currently is at 53%. Now, the unique thing with regards to ours is not that it's gone down, but it's that it's gone down a lot since the pandemic. There has been about a 14 point drop in the trust level of public with regards to like doctors and stuff. And I think to address that, we can't just start by saying, why doesn't the public trust us? Because that just shifts the blame the other direction. I think we should also start asking things like, why are we not trustworthy? And how can we become more trustworthy? And I think the things that Neha cited earlier are things that we could all do at an individual level to be able to create more trustworthy environments. Um, with regards to like trust too, sometimes I think what we do is focus a lot on historical mistrusts that have been done to certain communities, as opposed to addressing the current experiences that people actually face. And I think a perfect example of this was the John Hopkins studies that was done in the year 2005, where they saw that for Black patients, their awareness about the Tuskegee didn't predict whether they trust or not trust like the healthcare system. It is in fact their own individual experiences that determine where that mistrust lies. And so while isolated events like the Tuskegee are normally more cited when we talk about mistrust with regards to certain communities, we have to realize that the daily interactions that these people have with the medical providers are as important, if not more important, and do what needs to be done to be able to not perpetuate the narrative that has been long going. I think personally, as someone with a background in nursing, and also with the awareness that nurses have been the public's most trusted and regarded as the most honest profession according to the Gallup polls for the last 2 decades. I think that is something that we can learn from. Not that nurses do some things that we don't do or we have to act as nurses, but the things that make nurses more trustworthy are things like reliability. So they show up more to the patients, not just to give news. Sometimes they show up just to listen to what the patient has to say. I've experienced this where like a doctor comes in and talks to a patient for 15 minutes, and then as soon as the doctor leaves, the patient turns to the nurse like, what was he talking about? So it as if all of what was said to this patient made no difference with regards to what their baseline concerns were. And they depend on those nurses to be able to address those underlying concerns, and that makes them more trustworthy. So we can, as doctors, not spend as much time as the nurses do with the patients because the structure of healthcare doesn't allow for that to happen. But we could try to be more so listeners than talkers. Rather than telling people the answers to questions that they don't have, I think we should start addressing the questions that they actually have. And a better way to do that is to first listen to the patient. And I've observed that in my little time that I've spent in healthcare, patients don't care what you know. They only care what you know once they know that you care. So you have to show that you care for what you know to be relevant to who you're talking to.
Thanks so much, Omar. Um, Gabby, Ben, maybe one best practice. So I want to leave a little bit of time for questions. So I'm going to move you guys along, but maybe one thing that you think listeners to this call can take away, start implementing tomorrow.
Well, I'll just jump in because I see a questioner. Answered a few questions live in the chat just now, but I haven't answered Colette Cunningham's question about hantavirus. I would love to see. So the question was, what did we think about media framing of the hantavirus? And we haven't talked that much about media and news media. I was a bit bemused by the hantavirus coverage because we have so many more serious health threats around the world that warrant more coverage than they're getting. And yet here we had a relatively specific outbreak on a cruise with the epicenter on a cruise ship that got massive coverage. Why did it get massive coverage? Well, I was a journalist for most of my career, and it's because it's an incredibly gripping scenario. Bunch of people on a ship with this hantavirus and so on. And I would love to see newsrooms exercise a bit of restraint and try to manage coverage of health threats in a more proportionate way. Because you exaggerate threats when something like that is dominating the headlines. I had people from my past life contacting me from Wall Street and other places saying, should I worry about hantavirus? And and then you have terrible health threats, whether it's the cholera epidemic around the world that get no coverage. And I get why. It's you get more readers and eyeballs, but really, news organizations have a responsibility here when you're talking about people's health and well-being around the world. That's my plea.
Great. Thanks, Gabby. Ben?
Yeah, I think one of the things which so-called expert scientists particularly are not very good at is conveying uncertainty. And there's good evidence that actually that builds trust. And it feels counterintuitive because you feel like if you say, I don't, I'm not quite sure, or this might do this might do this, or we don't know, like with COVID, we don't yet know how this spreads, or this is our best guess for now, but we'll know more later. It can be quite an uncomfortable feeling, particularly when the kind of content creators online who have no facts are extremely certain. But actually, there's really good evidence that conveying your uncertainty actually helps build trust. So that's something we should do more of.
Great. Yeah, yeah, I love that. I think certainly like humility and authenticity are things that we hear from patients every day are more important. And I think once upon a time maybe it was in my experience in the NICU, once upon a time it might have been it might introduce doubt in someone's competency if you said I don't know, but it seems like now that level of honesty, transparency in an era where people can fact check you pretty quickly is integral to building trust. A bunch of additional questions, some of which I know we've already tried to address, but I think one thing that there's a really nice question here. Which is about sort of collaborations with technology companies. I think this is, an area that has sometimes been seen a little bit as a third rail by nonprofit institutions and multilateral institutions. But I wonder what the panel thinks in terms of the opportunity to collaborate with technology companies, such as the person who wrote this question, Mariotti, mentions Verily's involvement in the mosquito control programs, and the potential for those collaborations, but also the risk that those can foster conspiracy theories. How does the panel think about communicating about situations in which private industry may be lending a hand, and they may be doing so at least from every observable way, because they authentically, genuinely care about a given issue, but then find themselves thrust into this conversation of conflicts of interest? How can you address conspiracy theories and other narratives, and how do you try to frame conversations around these collaborations in a way that can expand the role of people other than traditional health institutions in promoting public health, especially in an era where traditional public health institutions are seeing their resources cut very seriously?
So you're asking about private sector collaboration and partnership and such, right,
Yeah, and
Eli?
how do you
So,
communicate about
yeah.
that?
Well, I mean, private sector is huge. So let's talk about tech companies in search versus pharmaceutical companies versus food and beverage, sugary, salty, fatty food and beverage companies, tobacco, infant formula. There's a lot of different things. But I actually think the common approach, and this is one that I took with my department at WHO, because we worked a lot, especially with tech companies on whose platforms we were disseminating information. And yet we and our followers were vulnerable to the algorithms, right? You have to both work with them because the data they have is gold. They have the impact data and they don't share it very much. The social media platforms, the search platforms. So you need to work with them to the best of your ability to make sure the content you're disseminating is reaching the people you want to reach in the most engaging ways, et cetera. But you have to push back and you have to be frank. And I had very difficult conversations with these companies saying you have to do better. I remember saying to Facebook, then Meta people, which is when you're on your deathbed, you can say to yourself that you saved hundreds of millions of lives. So you should really adopt really great health best practices across your platforms, rather than saying you garnered huge profits. You can do both, but you want to save people's lives and help people live great lives. So I think you have to have really tough conversations, and you have to be realistic and work with them because we're on their platforms, and unless we start creating our own platforms, we're on theirs, it's not that much different from the old days when we were on news media platforms, right? We were in the pages of papers. Now we're in the algorithms and digital platforms of others. It's very rare
Yeah.
that you can directly publish in an unmediated way.
Yeah, well, we can have an entirely different conversation about how to think about different platforms and the role that communicating on different platforms can play. I think the last question that we have time for is a really nice one from Ebony, and Ebony is asking about this example, Gabby, that you brought up of the masking lag, saying that WHO like actually potentially had the evidence to support guidance around this for months, and other non-pharmacologic interventions for months before they engage. And I think, whether or not, without getting into the particularities of that assessment of, where things were and, whether the WHO was or wasn't communicating, I think the bigger question that I see behind this is, when is the appropriate time to jump into the fray? Right? Healthcare institutions traditionally wait until there is a preponderance of evidence before they're willing to engage in these conversations. And I think anyone who has read, for example, Dua Eldeeb's wonderful reporting on most recently vitamin K, but before that, COVID placentitis, they will know that whether or not health institutions are engaging in these conversations, the insidious forces will engage in the conversation and they will push information, whether it's deliberate misinformation, disinformation, or just bad information. And so, what is the threshold that people need to reach before they're willing to jump into the conversation? And do people on the panel think that health communicators should try to get in that conversation earlier rather than later, even when we don't have 100% evidence to support a definitive answer?
Eli, I'm going to let you finish that question, but I would like to thank the panelists and yourself because we've come at time. But we can go briefly over time for a minute.
I'll just jump in, and somebody has asked about this. I think the question is about what is evidence, and what my point about the masks was, things were going very fast, and experts had to sort of decide, do we have enough evidence? Do we have a preponderance of evidence? Do we wait for evidence? Do we take a precautionary approach? And what is the precautionary approach? Will what we think is the precautionary approach actually be too risky? And you saw that just now with the Ebola outbreak in the DRC, where early in the outbreak, people started wondering, could the Zaire Ebola vaccine, which is plentiful, there's a big stockpile of the Merck vaccine, could that be used as a stopgap to give some protection to health workers while we develop new Bundibugyo specific Ebola vaccines? And experts, and not just WHO, but experts worldwide, were very careful and cautious. And it's only in the last week and a half that they've decided, okay, we're going to start trying to give the Zaire Ebola vaccine to frontline health workers in Ituri province of DRC while we develop. So some of you might say, oh, why did it take, 2-3 months? 2 months, whenever it was. I think it was in early May that it was detected. Why did it take so long? On the other hand, you could say it didn't take long. That was pretty quick because you needed people to really assess what were the risks. So I think it's quite complicated, and I don't have an answer for how health workers should do it. The one answer I do have is open your minds, because if you come with an idée fixe about what is the evidence, what isn't, and so on, and you don't listen to others, you're certainly not going to budge from your position if you need to, if it's best for people. So intellectual diversity is really important in whatever we do.
Well, I share my gratitude to the panel for all of these really thoughtful remarks. Obviously, there's much more we could talk about today. This will be an ongoing conversation, here for all of us on the panel as well as for Stanford. I know there's a lot of programming through CIGH as well as through the Health Media Fellowship and other programming at Stanford to try to help people understand the landscape of information as well as train people up on how to communicate better, combat misinformation better, and reclaim trust with their patients and constituents. at least for today, thank you so much to the panelists. Thanks to the audience for joining, and we hope you enjoyed this session. Thanks, everybody.